Who shall begin? I can start this week. I've got a handful of quick cases.
Sure.
Okay, so let's start with this one. Get it loaded and then share my screen. All right, you should see a PA chest radiograph, Röntgengram.
Good.
All right, so this is let's see, we'll start with this one. So this is a lady with a history of breast carcinoma. You can see there's a clip deformity, who was treated with chemotherapy, radiation therapy, adjuvant therapy. And you can see she developed some consolidation in her left lung. And this was in January. I think she was treated for a presumed infection, although it didn't sound all that clear if that's what fit. Returned with ongoing symptoms, and this is about 6 weeks later. So you can see this area of consolidation has decreased, yet there's been development on the contralateral side there. So they got a CT scan to better assess. And we can see these nice areas of consolidation, ground glass, with very sharp margins, spared lobules. And when I see that, I think very highly of, or strongly of organizing pneumonia. You can see the radiation injury there. And her radiation was back in September. So we're, at this point, 6 or so months out, and you've got some nice just peribronchial foci consolidation with very clean margins, no small nodules or anything, no effusion. So, and then even a little tiny one down here. So, and she doesn't have any signs or symptoms of infection anymore. So our presumptive diagnosis, and we don't have pathology on this, but I don't think we're going to need it, this is radiation-induced organizing pneumonia, which has been well described in the setting of chest wall radiation for breast cancer. Usually occurs within the first year after treatment, typically no later. Starts frequently in the radiated lung, but then can spread rapidly. So we got migratory consolidation. So I'm sure you've all seen that before. I hadn't seen it in a long time, and I wondered if they had changed how they were doing the radiation, if they were able to sort of contour it a little bit better, but this is a pretty good example of that.
It's a very strange phenomenon, right? Because it's hard to associate radiation in one area with contralateral disease, but it's a well-described phenomenon, right?
Yeah. And you wonder if maybe the chemotherapy has something to do with it too, and there's sort of a synergistic effect. So,
Good.
All right. This is one some of you may have seen.
Jeff, can you hear me?
Yes.
Just really quick, one of our pulmonologists refers to it. There's a term called the abscopal effect, ABSCOPAL, and they talk about that in radiation therapy, where that's localized radiation that will trigger systemic anti-tumor effects. So through some sort of immune stimulation. So they kind of like to refer to it as like an abscopal effect of radiation as well. Where whatever the localized radiation just triggers a systemic response.
Mm-hmm. Yeah, that's the sense I make of it is it triggers some sort of immune response of some sort. Because, you don't see it with lung or esophagus. I've seen it once with esophagus, and it's been reported, I think, in a Chinese journal with lung cancer. But, they're giving the amount of lung injured is so small versus if you're doing lung radiation at such a high dose that you probably get more just local effect. But that's interesting. I'll have to look into that effect. So this is a case some of you may have seen. This is I forget how old she was, a 66-year-old woman who carries a diagnosis of sarcoid and has been treated for several years with that diagnosis, but not responding. This was her initial CT, and those of you who've seen it before would agree with me. It doesn't look very sarcoidy-like. We see central lobular ground glass nodules and some areas of lobular sparing. And one of the things I like to see are sharp fissures, because that tells me that the ground glass is more central lobular and not necessarily along the fissures. I mean, there are a few small nodules there, but overall, I get the sense this looks more like HP. And then we have some additional imaging. This is and these are some outside scans, but you can see the ground glass has gotten more conspicuous, and now we're 3 years later. The nodules, I think, are a little easier to see in some areas. And she still has that lobular sparing, which is confirmed. Actually, we don't have expiratory, but these are too noisy and too sharp. And then another scan also showing this at the time. And I think you can even appreciate there's sort of a subtle nodularity to it. So at the time, I was asked by the pulmonologist, you know, it was based on a biopsy, which I can't look at, but it was called sarcoid, or at least non-caseating granulomas, but there wasn't a lot of other descriptions. And you know, maybe she's getting a little fibrosis here. The question being is, could this be HP? And the sort of the sarcoid diagnosis is sort of a misleading, a spurious diagnosis. So at the time before we saw her, she had no known exposures, but the pulmonologist came by yesterday, and not only is her house full of down bedding, she was wearing a down coat, and there were feathers physically coming out of the coat. So I think there's a good exposure for HP, a CT that looks like HP, that's progressing like HP. She's not responding to immune suppressive therapy for sarcoid, which would make sense if she's got down all the time. So I think the point of this case is, you know, we do see granulomas in HP. They look a little different. They're kind of wimpy granulomas. But sometimes a biopsy can lead you astray if it doesn't fit the imaging right, or and their patients aren't acting like they ought to. She never had lymphadenopathy, never had any extrathoracic manifestations. And we think of this just doesn't look like sarcoid progressing. So.
Yeah, it's also a nice example of what I like to call gray lungs. When you look at the whiteness or the blackness of the lung compared to the blackness of air in the bronchi,
yes,
just a few background grayness of the lungs really is striking.
Yes, I think it was Rick Webb, but years ago talked about this black bronchus sign. Like you can see airways farther out of the lung than normal because of sort of reverse contrast. I like that gray lung.
Yeah.
All right. So, now this is a cool case. This was a consult fresh from this morning. This is a 18-year-old woman who had this mass on a chest radiograph. And you can see there it is. So it's posterior to the heart, and had this CT scan done elsewhere that shows this blob right behind the heart. Now you'll notice it's in continuity of the liver. So this blob is indeed liver. So there's liver coming up, and I'll show the coronals. So we can see there's liver extending into the chest through this diaphragmatic defect right here. Now, we've seen plenty of hernias. This is a little unusual, and it's funny, when she lies down is when she gets short of breath. You wonder if there's some mass effect or it's impairing return to the heart or something like that. She's got some other things going on. But I think David's going to like this part because, so one thing when I was looking at this, because it's a kind of bizarre, it's not a Bachelect, it's not Morgagni, but I noticed that the crus was thinned. And so I asked if she'd been involved in any trauma, and turns out indeed she had. 5 years ago, when she was a teenager, was in the back seat of a car that crashed and was thrown into the front seat, not wearing a seatbelt. So it almost sounds like a sort of a handlebar injury, because you can imagine you go over the seat, your abdomen hits the headrest or the back of the seat, and the rest of you tumbles over. And what I don't think was appreciated at the time I didn't have all the information, but I couldn't find any mention of it at the time, is that she did indeed have some liver already in the chest, and this lower mediastinal hematoma was not appreciated. And there's even some gas around there, which makes me a little nervous where that came from. And then you can see there's a little bit of extrapleural blood tracking along just down there. So, and even then the crus she was younger, but the crus looked like it was a bit more robust. She did have a splenic lac, very tiny little guy down here with a little bit of hematoma. And that was the only documented injury at the time. So there is an association with sort of diaphragmatic and splenic injuries. And this is, I showed you that diaphragmatic hematoma. I think this is not in the crus, but next to it. And there indeed was a rupture at that time that was not appreciated. And now it's just more conspicuous as she's gotten a bit older, larger, and we just see more of the liver in there. It's right there. So,
wow.
Yeah.
Oh, Jeff?
Yeah.
Jeff, are you saying there's a hole in the crus, or?
No, I'm saying I think there's a hole in the central tendon.
Okay.
But the crus had thinned out a lot more than you can see the asymmetry of the crura really nicely here.
So you think that's because it's retracted, or
because got injured?
The nerve supply is damaged to it, or what?
Yeah, I think it was damaged and injured, and who knows how many of the phrenic nerve branches were injured at that time.
Okay.
Or she,
Wow.
alternatively, she was born with a thin diaphragm that ruptured. But looking back 5 years ago, I think that cruise, if I get to go back, was a little bit more robust. I mean, even then there was some asymmetry, but even at this point, it was already injured. But considering there was blood around a little bit up higher near the esophagus here, I'm pretty sure that that's the cause of this, because this is a weird hernia for something congenital.
Yeah.
You know, and clearly she has a mechanism for it, and she has the associated injuries. So,
yeah, that's an unusual location, of course, for traumatic injury, but
right. But we also, these diaphragmatic injuries are easy to miss, and a lot of them go unrecognized. I think now that our CT scanners are better with you get the multiplanars that look real, but remember, back on the 4-slice scanners, you couldn't get these decent sagittals and coronals, and it was easy to overlook some of these injuries. It's just in a weird place.
yeah.
Okay, last case here. This is sort of interesting because it's two things, but want to make a couple of points. So this is a patient with multiple myeloma and had signs of infection and had this mass-like area of consolidation, some small nodules, ground glass. This is known adenovirus. This was cultured out of this. And just it argues to the point that even viral infections can give you sort of a area of consolidation. It doesn't have to be diffuse or bilateral. And I have a couple of cases I've seen of adenovirus presenting with a more focal area as opposed to diffuse areas of abnormality. But what's I think more interesting about this when we were looking at this case is we noticed all these soft tissue masses around the spine. There was some in the upper abdomen, and then some in the extrapleural space. There's a new one in the breast, and these had all developed just over a fairly short period of time, right? You see all this paraspinal soft tissue, this what looks like extrapleural, and it's very high attenuation. And so, myeloma, and then there's this one here, you think about, well, could it be extramedullary hematopoiesis? But usually that's with long-standing anemia, thalassemia, rarely sickle cell, which she didn't really have. This is likely extra osseous myeloma, and these are all just deposits of plasma cells. I don't have tissue confirmation on it, but it fits with everything. She's got some lesions associated with rib fractures. It's kind of everywhere. So I think that's what's going on here, and that seems to be the thought of the hematologist as well. And so it can present as masses. Trachea has been reported, can mimic other soft tissue masses, but it can occur like that. So as opposed to an isolated one. And I always wonder if it extends directly out of the bone, or if it's just the plasma cells find a place to set up shop. But if you
the spine looks very porous there.
Yeah,
the cortex
trying to
intact. You can really understand it leaking out.
Yeah, that's what you wonder, right?
Yeah,
because there's quite a bit of it paraspinal, which is where most of the myeloma is. And then she's got these fractures, but explaining the one in the breast, I don't know how to explain that one, but that thing popped up in a very short period of time. It's not a breast cancer, so presume that. But it's just a nice one. But I also like it for the point that this illustrates that we can't distinguish bacterial from other infections very well, but the lack of pleural effusion makes me lean away from your run-of-the-mill bacterial infections, especially in someone who's had it for a little bit. Fungus, it could be fungus, but all the cultures were negative. They bronked right down in here and got plenty of adenovirus on the PCR. So
very nice.
Yes. So when infectious disease comes down, I kind of shake my, shrug my shoulders and say, yes. What could it be? Yes, right. But
okay. So, Jeff, we'd accumulated about 12 cases of extraosseous myeloma that I was wanting to do a pictorial essay on for JTI. Have other people seen this? So, Howard, have you or Travis? Extraosseous myeloma?
Don't recall offhand.
Okay.
Someone.
I showed that case of that big pleural mass that was like fat and soft tissue and calcification probably 3 or 4 years ago. There was extraosseous myeloma.
And I showed one that was diffused through the lung as small nodules. It was
thought
amazing.
someone, and maybe I have it, and it was from a while ago. I thought someone showed a tracheal mass that was a plasmacytoma. No, you know what that was? I think it was when I was a resident. They used to have that pulmonary conference at Harborview, and I think one of the cases was an extra. It was a tracheal or subglottic mass that ended up being a plasmacytoma.
Wow. Okay.
So, David, are they cases of myeloma or plasmacytoma or both?
Well, they're cases of soft tissue and pleural and lung tumors in the setting of myeloma.
Yeah. Interesting.
I think we ought to get that moving. We'll probably go ahead with that project then.
All right. All right. Well, who would like to show the next set of cases?
I have a couple.
All righty.
So here's a straightforward case of somebody whose body is arranged in the wrong direction and who has some bubbly lesions and chains down here, bubbles and chains, looking like bronchiectasis. And, you know, CT just sort of gilds the lily here, lots of bronchial disease, more pronounced in the bases, small airway shadows too. So a lot of pus or mucus or accumulated stuff here in some of these big airways. So this is Cartaginer. I don't have any sinus series on this person, but this person has a known ciliary dysmotility with situs inversus. So pretty straightforward case. And then I need your assistance on this case. So this is a young woman who had some treatment with rituximab that ended last April, and this was because she had idiopathic thrombocytopenic purpura. So she was treated with ITP with rituximab, and when she went off the therapy, she became ill, and then she has a series of abnormal CT scans, and I'll show you the culmination of this abnormality here. So here's what her current CT scan looks like. She's got a bunch of pretty well-defined lung nodules that are basal predominant. Some of them are peripheral along fissures here along the edges of the lung. Just bizarre looking lesions like this. And these were biopsied, and they found that there were necrotizing granulomas. So these lesions are mostly necrotizing granulomas. And they looked for things that would tie it to EGPA and lymphoma and things like that, and none of those markers has held up. So we have this bizarre set of nodules. And let me show you what her original CT scan looked like back in April after she'd been off of the rituximab for about 3 weeks. She had this, she was feeling badly, and she had this widespread lung consolidation. A lot of it is central around airways, and you'd think first of infection. And then, but there's a series of blobs that are out against the periphery of the lung, like this. And on subsequent CT scans, I'm not going to show you all the intervening CT scans, the central stuff went away, and we're left with a lot of peripheral stuff that looked like this in a lot of locations around the lung. And then ultimately, she ended up with those discrete nodules that I showed you that on biopsy had necrotizing granulomas in them. So, you know, sarcoid doesn't cause necrotizing granulomas very often, but there is necrotizing sarcoidosis. But there were so many lesions here that the cases I've seen of necrotizing sarcoidosis had just a couple of lesions, you know, 1 or 2, and the lungs weren't full of them like this. And this isn't a typical sarcoid distribution being basal predominant like this. So I wonder if you guys have any other ideas about what this might be.
So David, just to go back, she is or has been treated with rituximab.
Right.
Developed something that looked like consolidated lung at some point, and now she's got these nodules, right?
Yep.
I think that just based on that clinical information, one would worry about an infection. Of course, necrotizing granulomas, the pathologists say the same thing, but I'm sure they've done all those stains.
They did.
But could it be a case of an infection that we just haven't diagnosed yet?
Yep. So, I mean, they look very hard for
therapy.
Everything was negative, including a lot of PCR, I think. Go ahead.
No, I don't have any ideas. I was just thinking necrotizing granuloma, infection, the person that's on anti-B cell therapy, at least.
So, Jeff?
Yeah.
Jeff, could you blank my screen temporarily here, or can I do it?
I think you can do it if you hit the pause button.
Okay. Did it go blank?
No, but I just see I see the same image.
Okay. So so I just want. Can you see my desktop there or not?
No.
No.
Flash ID. Okay. Let me pull up an article here while the screen is paused, and let me bring up this article as a speculative possibility for this. So I can unpause me here. So, you know, when we've seen sarcoid-like reactions when people have their immune system messed up one way or another through medications and all, and you know sometimes that manifests as sarcoid. So people when you see granulomas in the lung, people think about sarcoid. So this could be an unusual sarcoid that has a necrotic component, but the distribution is kind of weird. But one of the iris phenomena, this immune reconstitution syndromes, they can be sarcoid-like. So here's an example that I pulled up yesterday of this paradoxical immune reconstitution inflammatory syndrome associated with rituximab-containing regimen. So this is the agent that she was on. Did I say it right, or did I give you another agent? I did say rituximab, didn't I?
Yes, it was. Yeah, you said rituximab.
Okay, so in this person, there was this cervical lymphadenopathy, and on biopsy, they determined that it was full of necrotizing granulomas here. So I'm just wondering if this is iris from withdrawal of the rituximab. So, you know, the patient is just being seen in clinic and evaluated. I discussed this with the pulmonologist a lot, and she went through all the negative results that have resulted so far, and the pathology has been reviewed here at UW. And so I'm just tossing this out as a possibility. I wonder if anybody else has seen any bizarre lung manifestations that might be immune reconstitution in the setting of withdrawal of rituximab. So
I'm not seen it, but I think it's a good theory.
Yeah, I like the theory just for the theory itself, regardless of the data. So, okay, so maybe
you were go in the cryptococcus direction.
Yeah, so that's all been checked for. Believe me, people were concerned about fungal infections and a whole bunch of stuff.
Wow.
Okay, so I wanted to just leave you with that teaser, and if more information is available, I'll update. Okay, I think she's going to get a repeat CT now because this one is 3 months old. So I do believe that these nodules evolved from the earlier CTs. So I only showed you 2 CTs in the sequence, but there were intervening CTs that showed more and more peripheral stuff, looking like organizing pneumonia, being way out against the periphery of the lungs, concentrated in the bases, and then ultimately we're left with these nodules. So, I'd like to say that this might have been a drug reaction sort of thing back then with organizing pneumonia, and then it has evolved into these caseating granulomas. Okay, enough speculation. Jeff, those are the 2 cases I wanted to share.
I have one point to make about your other case, and I think this is something we can pass along down the generations, is the eponym for your situs inversus and bronchiectasis should be pronounced Cardigainer, because he was born in the Austro-Hungarian Empire in a German-speaking area out of a German family, and then I think worked in Switzerland. So he wasn't French. So the G is hard in German.
Yeah. So
that's all for you to mispronounce that. That's just
I know, but I always, my residents know better ever to say, they know how to pronounce it correctly. Because I looked into this one time, and indeed he was not French, but of Germanic descent.
And
You know,
Epstein is an Epstein anomaly. It's Epstein, according to Sonny. He was German as well.
yeah. So in Wisconsin, there's a lot of people who are knowledgeable about German
Yes.
language.
The second
Yeah.
most common spoken language,
But,
English.
there is this urban legend about the pronunciation that should be Cartagena, and the urban legend goes like this: and people were at a conference and somebody was describing up their, with slides showing Cartagena syndrome, and somebody put up his hand in the audience and says it should be Cartagena, and there was some skepticism about this. Well, who are you, sir? Says, I am Cartagena. So I doubt that really happened, but it makes a great story.
Yeah, I've heard that same story, and I wonder. I can't find any documentation of it, but I can find that he, as far as I can tell, he never resided in France.
Yeah.
Okay. Thanks.
Good one.
All right. Who's up next?
I got 3 quick cases.
All righty.
Let's see here. I don't know which monitor it is. Let's try this one, see if that works. Okay, so this is a quick case that I came across a couple of weeks ago. That's just a little atypical from what I'm used to seeing with this process. So this was a young kid. He was in his 20s, had undergone a lobectomy, and you always wonder why a young kid undergoes a lobectomy. And you can see that there are these little stalactites or things kind of hanging down into the trachea. And sure enough, if you go back to his original study, he came in with a large right upper lobe mass, which was squamous cell, which was HPV positive. And you can see these little nuggets of papillomas hanging in the trachea. With this process, I have always, in the few cases I've seen evidence of papillomatosis in the lungs. The little nodules or little cavitary nodules. And I'm just curious how often you guys have seen HPV-induced squamous cell carcinoma in a young patient with tracheal findings, but without any other parenchymal findings besides upper lobe cancer.
No, I've not seen it.
No, never have.
Not isolated.
No.
Yeah, I was, really looking elsewhere, and I couldn't find anything. I searched the lungs extensively to find some evidence. Couldn't find it, but it was an HPV positive squamous cell, and he has known, documented HPV in the trachea. Okay, so that's that case, and this is just a. Oh, let me show. Nope, stop. Let me show this, because this was one where I made a incorrect stab on the chest X-ray. I saw this, and it looks a little blurry here. I apologize, but whenever I see this, a patient with a large, well-rounded mediastinal mass in the setting of sternotomy wires, I'm always just thinking about a coronary artery aneurysm, and I saw this, and we recommended a CT, and I said, oh, this is going to be a nice coronary artery aneurysm from bypass, but kind of what you would assume, or at least what I assumed, but this actually turned out to be a gentleman who had one of the larger, so here's the lesion, partially calcified, looks good here, could be a aneurysm of the RCA, but you notice that this gentleman has had a aortic valve replaced. He is a drug user, and I don't know if this had anything to do with drug use, but he has this pseudoaneurysm. So there was a clear gap in the wall of the ascending aorta, just above the sinuses of Valsalva, kind of near the sinotubular junction. And you can see there's just a defect in this very large pseudoaneurysm, which had presumably been there for a very long time. His valve replacement was 20 years ago, and he's probably been walking around with this thing for quite a long time, but they fixed it. And it's just a very nice, big aortic root pseudoaneurysm.
Whoa.
Yeah, and there's some, I've seen a lot of these cases where someone you're shocked at these people. And I always do delays on if I'm concerned about a cardiac mass. And this here, again, that didn't help much, but it didn't really feel after that. You still have this little area that's filling, the rest of it's completely thrombosed and calcified. And then lastly is just a a nice example of a patient with known TS with multiple AMLs and had the right kidney resected, a lot of fatty lesions in the liver. And then what I like about this case is the cardiac involvement. We know we get these fatty myocardial deposits. Pathologically, they actually, more characteristically from what I've been told by our pathologist, represent lipomas and not myolipomas. But this is one patient that's had more than I've seen. Usually in the cases of TS with cardiac involvement, I see, you know, 1 or 2 little lesions and not this number of small fatty deposits. Unfortunately, we don't have any imaging besides a non-contrast CT. And most of them usually I've thought to be myocardial, but this patient had them all over the place, subepicardial. But they're all within the substance of the muscle of the heart. But I just thought that was a nice, and I didn't see any parenchymal findings. You know, you're thinking of TS, didn't see.
How about the bones?
Oh, he's got a few cysts in there.
He does have a few cysts. Yeah, he does have a few cysts, but I never know. So, okay, so question to the group. If you have a guy with TS and a few cysts, and we probably did. I just found this case because someone brought it to my attention, but I would actually probably call this lamb too, huh?
Right. I think it's reported in somewhere about 15% of males with TS, but they rarely have enough disease to make them symptomatic.
Okay. Yeah. No, because I'm looking at it, and honestly, I was so obsessed with the heart when someone showed me this case that I didn't even really look at the lung. But yeah, there is. But I would call this lamb.
There's probably only about 10 or 15 cysts in there, so it's not.
Yeah. Not a florid case. And the bones, let's see. Again, I didn't really. Oh.
Yeah, he's got those sclerotic bone lesions like we see.
Yeah, yeah. So in the here.
Yep.
So a few sclerotic bony lesions. Again, I should have looked at the whole thing. But
what do they represent? What is going on with the bone sclerosis?
Yeah, I didn't even. I'm not sure. Travis, do you want to?
They're like bone islands. I showed a case like a month ago, and there was a paper in radiology within the last 7 or 8 years talking about differentiating lamb from tuberous sclerosis complex. And if you have, I forget the number, more than 4 or 5 of these sclerotic bone lesions, that was pretty specific for tuberous sclerosis.
Another one up here.
There's one in the rib there. That's really interesting. Wow.
And the liver are lipomas or AMLs?
In the heart?
No, in the liver.
Oh, I don't know. I would assume they're AMLs in the liver. That's what I've been told. I don't have path on this case, but I would assume, I thought they were hepatic AMLs. Any of you guys, any other input on the liver stuff?
No, that sounds reasonable.
Yep.
Yeah.
Very, very cool case.
Okay, so more than just the fatty stuff in the heart. He's got kind of the whole thing then. Nice.
Yeah, nice case. All right.
Very nice.
All right, those are mine.
Everybody on that one.
Yeah.
Let me try and show one here, Jeff.
All right.
While Seth is still on here, I'm glad that he is around. Hopefully my streaming works from here. You see this rankinogram?
Yeah.
Yes.
Yep.
So this is as you can see, a 53-year-old woman. This is back in 2012, and I think this is pretty much normal. Maybe you can argue there's a little abnormal convexity here. But anyway, she ended up, as you can see, a year later getting a PE study at an outside hospital. And her right atrium and her right ventricle are kind of borderline dilated. But what they found on this study was just that her main pulmonary artery is aneurysmal. And it's really isolated to the main pulmonary artery. It's not even the left pulmonary artery. And she was asymptomatic or really no symptoms that were referable to this. And I wonder, just as a brief aside, looking at the radiograph, if you're just getting the aorta kind of pushed to the side here because this PA is so big, because you really don't see the pulmonary artery on this radiograph. Even on the lateral view, maybe you can argue that you see, a little here, but that's nothing. So, but anyway, so she gets $1 million workup for this, and it included a echo, MR, everything outside, and they suspected that she had pulmonary
I mean, there was some weird.
I'm getting to that. That's exactly right.
Okay.
Yeah. So she had this study at our institution last week, and one of my colleagues, credit to Kim for seeing this. When you look at the pulmonic valve, you can see that it's thickened and looks like it may be a quadricuspid valve. When you do an NPR, you see that in fact it is a quadricuspid pulmonic valve.
That's really neat.
Yeah. So and she'd already undergone a right heart cath for evaluation of her pulmonary hypertension because of her pulmonary artery enlargement and all that. But the theory is now that this is just quadricuspid aortic or pulmonic valve with an isolated pulmonary artery aneurysm. And let me just get rid of that so you can actually see it. But it's a pretty nice view right there.
Yeah.
And you know, and Seth, as we wrote in our mosaic attenuation paper, you know, there's really no findings of pulmonary hypertension here other than the isolated enlargement of her main pulmonary artery. Her segmental arteries aren't any bigger than her bronchi. Her right ventricle maybe a little dilated from just pulmonic insufficiency, but certainly no hypertrophy there.
Yeah.
But yeah, I was able to find, I don't know, some case report left a pulmonary artery aneurysm in an asymptomatic patient. So this is really an incidentalloma that led to a pretty substantial workup in this lady. Now this case was more main and left pulmonary artery. I didn't really like their conclusion in this paper here, that they concluded that this was, you know, they considered this pulmonary artery aneurysm to be idiopathic, because I bet it's almost certainly related to the valve. Just like with a bicuspid valve, you get a bicuspid aortopathy or pulmonary artery enlargement. So I don't know. Have you seen one of these before, Seth?
No. I've seen a lot of bicuspid pulmonary, but I've never seen a quadricuspid. I've never seen a unicuspid. Oh no, I've seen one unicuspid pulmonary. I've never seen it. Never seen this. It's pretty cool.
I find it hard to believe that it's idiopathic in this patient and in our patient. I bet it's related to the valve.
Yeah, I'm sure.
But Travis, is the mechanism post-stenotic dilation? I mean, is there a stenosis, jet, and turbulence that might create the dilation, or is it thought that there's a mesenchymal problem that the valve and the wall of the aorta?
Probably both. You know, like you said, with bicuspid aortopathy, those patients have abnormal wall as well. So I don't know. I would guess that there's something abnormal in the wall with the development.
I think it's both too. Okay. But that's speculation, but I always thought it was both.
But yeah, I think the conclusion is, as you correctly saw on there too, Seth, is like if you have pulmonary artery enlargement, that always look at the valve. And in this case, even though it was a non-gated study, we were able to see that it was quadricuspid.
Yeah, it's funny. I had a case like this where not with the quadricuspid, but similar thing, big PA, classic PA stenosis on CT, on non-gated CT, and they get an echo, and the echo reads it as normal. And you have to remember, echoes are awful, and they're especially really bad transthoracic looking at the pulmonary valve. And, you know, convinced the clinician to get an MR. MR showed classic pulmonary stenosis, but they still didn't want to treat the patient because the echo was normal. Just like, dude.
Yeah, exactly.
It's like, all right, fair enough.
I'm going to show this one really quick. This is one I emailed you guys about yesterday. This is a patient who came in 2016. This has all been done elsewhere. You can see even here, I would argue that his trachea is a little thick in this case. And then he's got some centrilobular nodules and nodular consolidation, mostly in the lower lobes. You can see that right middle lobe bronchus is pretty tight here. I think this is the more recent study, yeah. And you can see now, like, this trachea is way too thick. And so the pulmonologist brought this to me, and I guess my first thought was maybe relapsing polychondritis, but maybe there's a little bit of involvement of the posterior membrane. And this is a guy, and you can see here the main stem bronchi, because it has that kind of RPC look to it. But anyway, he's had this just recurrent infections, persistent nodules and consolidation. As you can see here, ended up undergoing a wedge somewhere else. And the wedge of his lung, so not his trachea, but of his lung, stained floridly positive for IgG4.
Really?
Yeah, so the question is, and that was the question yesterday, is this an IgG4 tracheitis? And I have no idea. I said maybe, kind of like when the infectious disease people ask you, could it be this infection? You say, with IgG4, I think the answer is yes. But I don't know. I wish they had a piece of the trachea, but they don't.
Or it's two different things. That's peculiar.
There was nothing
Yeah,
in the nothing in the ear or nose or anything that pointed towards
No.
relapsing.
No, and it's a 60-year-old guy too, not a 30-year-old woman.
Yeah, fair enough.
But it kind of has that thickened, inflamed cartilage look to it.
Yeah,
but
no, it does. I mean, it looks like, yeah.
Yeah.
All
I don't know.
around. How about the posterior membrane? Is that involved too? Can we make?
No, I think it's not, because I think when you look at there's a little respiratory motion here, but I think especially when you look at the bronchus intermedius, it looks fine. And here maybe a little, but it doesn't really look that thick. Because yeah, then you're like, is this some sort of granulomatous infection or amyloid or something? But that's actually, I thought it was going to be some sort of granulomatous infection with the nodules and consolidation, like TB or cocci or something weird. But all they got was IgG4, so I don't know.
Travis, if you don't mind, I have a quick case that was sent to me by a former.
Yeah, that's it for me anyway. So
okay, this will be
yeah,
real.
please switch over.
It's related. It's an IgG4 case. This is I don't have DICOMs, but I have a cine of it. You guys can see this? This patient presented with all these nodules. Kind of looks like David's case. They cored one of these, and it was all IgG4. But there's a couple of things I noticed about it that I found interesting. First of all, there's a few cysts, which may have something to do with protein deposition. But also, you'll notice the distribution of the nodules is they're similar to sarcoid nodules. They're lymphatic. Many of them are around airways, but they also tend to spare the airways. I found in some of them, if I can scroll slowly enough on here, I saw air bronchograms right here, like you typically see with other lymphoproliferative disorders in the chest, like we do with lymphomas and lymphoid hyperplasia. But yeah, I don't think I've seen this manifestation of IgG4, but it seems like it would make sense. But I mean, like for example, right there, you got a beautiful air bronchogram going right through there. So, but
it's really interesting that this case, like mine, is very asymmetric too.
Yeah.
It's a lung involvement. It's weird.
Yeah.
Makes you wonder if there's some infection precipitating this.
You kind of get the sense, don't you? All right. Well, cool. All right, Howard.
Okay. But Travis, in your case, the bronchioles and the small bronchi contain stuff in their lumens too. It's weird.
Yeah, I agree.
Okay, this is a fun case. So play a little game here. These are two different patients, and I'll give you a moment to take a look at this. And you'll see how it ties in a moment. So take a look at that for a moment, and I'm going to say that this is one of the times in radiology when, for fun, you can kind of play the game. It's kind of the game where you shoot first, ask questions later, but if you're brave, you can make a diagnosis and then ask questions later. So let me actually zoom in here. I'm going to zoom into the right lung and zoom into the right lung and give you a moment to look at that. And of course, I don't know how it's going to show on your screens where you're at. I hope it shows relatively well, but I'm just going to give you a moment to look at that and then say it's the same thing. And those of you that have seen this before, pattern recognition, Mona Lisa kind of thing, Ant-Mani, might be thinking of something. Just tell me, for the game, can you see an abnormality just on your screens? I don't know how it's going to project, but those of you that have seen this before, maybe.
We think of the image on the right, we see holes.
Okay, so you do see something. Good. Okay, so I'm going to say one word, smoking, and give you, now don't say anything yet. So those that are watching the video can start to think. So let me make it even a bit bigger and make them about equal. And think about what you might be thinking of. Now let me go out of here entirely and show them separately, starting with one here again. So that's that first patient. Now I'm going to bring up alongside a CT for you. And here you'll see the nice correlation. So there we go. That's a MINIP image. So let me bring up another one first. There you go. And of course, what I was hoping that you would perceive is a fine reticulation and small little holes in those lungs, with the lung volumes actually being very nice. And let me show you the thin cuts because they are really nice too. So I'll bring this up separately and scroll through there and give you a feel for that. And look how gray the lungs are, and they're going to get a bunch grayer and even grayer all the way down to the bottom. So undoubtedly there are trillions of smokers' macrophages in these lungs. We begin to see small cysts here. And although this was described by one person in part emphysema, I think personally these cystic spaces are super typical of Langerhans cell histiocytosis. They're very bizarrely shaped, and more than just emphysema could be, I think. So I think this is florid smoking-related disease.
Yeah, and I think case illustrates the point that, you know, we talk about these different smoking-related lung diseases, but in fact they coexist, and, you know, one or more may be dominant. In this case, you have features of LCH up top, and then yes, your denser lung is what we probably, I like to use the word used to call DIP because it's a bad name, but you know, you've got these large ground glass areas, you've got well-defined thin-walled cysts in them that can be seen. A great example of black bronchus sign all throughout.
Yep.
And then you see some central locular ground glass nodules too. So what we used to call RB, it's kind of this smoking-related diffuse parenchymal lung disease that has many different manifestations, and depending on which one dominates is how it impacts what the CT looks like. But that thin-walled cyst right above the diaphragm in the right lower lobe is more typical of the old DIP name as opposed to LCH, and it's in the wrong place for LCH.
Yep. Beautiful example of that, huh? Pardon?
Can you go back to the upper lobes?
Sure.
Yeah, you know, I think some of that is probably emphysema, but some of it could be PLCH. The question is, what do you call the ground glass stuff around the emphysematous spaces in the upper lobes? Because there's really not a terminology I use. Presumably it's some degree of smoking related fibrosis. We know that we get some fibrosis in the alveolar walls from severe smoking. So what do you guys call that when you see, let's say, even if it's extensive smoking changes in the upper lobes with some ground glass, and forget the stuff in the lower lobes?
I still call it smoking related diffuse lung disease.
Yeah, that's what Galvin uses too. I mean, but I'm saying in the, yeah, I mean, I kind of,
I call it. I kind of bundle it all together, and you know, in this case, I might say, you know, with features, including features of Langerhans cell histiocytosis, and because I think that's going to be potentially, if the patient's still smoking, maybe if you want to call it the rate limiting factor.
all right.
Yep, that's the way I approach it too. Yep.
You know, some of the ground glass in the setting of emphysema is just relaxed lung, because certain parts of the lung are puffed up. That means that the lung around it, where there's still some elastic recall, are going to pull together, and it's just denser tissue with less air in it. So sometimes it's just atelectasis, and I've seen people, particularly with basal, lots of apical emphysema, basal ground glass, a lot of dependent atelectasis. You flip them on their tongue, and you re-expand that lung, and all the ground glass goes away. So I think there's really an exaggerated atelectasis associated with parts of the lung that are puffed up. So I think that's part of it. Now in this guy, it really looks more inflammatory.
Yeah.
Interesting, huh? Yeah. Okay, let me go back to the case number 2 or case number 1. Let's see. So that was case number 1. So this is the other person that I showed you, and you'll like this one. Here's the corresponding coronal. And that's why we see what we do. So this is a beautiful example. This guy's only 29 years old and has got lungs that look like this. So he's got very extensive involvement, even of the lower lung zones. And he's got the whole plethora of findings. So he's got the little nodules, he's got the little cavitary nodules intermixed with all the big cystic changes. So super typical for smoking-related Langerhans cell. And then let me show you the follow-up, and you'll see that he did stop smoking. So let me just make sure I get my dates correct. And you'll see that we have a couple of months between the two. And let's say I go to the lower lungs. I think what's resolving are the small nodules and some of the cavitary nodules, or things look better over that period of time.
Mm-hmm.
So apparently he has stopped smoking.
Looks as if there's a lot less of the bronchial wall thickening and the thickening around the stuff like that. So I think the inflammation has died down, but the holes are probably permanent.
Yeah, some of the big holes are. But there's definitely less opacity. Maybe some of the small little nodules or cavitary nodules have seemingly disappeared or better, but overall this looks a little bit better to me, visually. Anyway, so 2 super nice cases of. So I think that those imaging findings that I showed you on the radiograph, they're subtle, but if you have seen them before, you can just say Langerhans cell, mixed case, particularly if you get a history of smoking. It's a very distinctive appearance, albeit kind of subtle. I have a few more, but I think we can quit. Maybe it's 1 o'clock, 2 o'clock my time.
Okay.
And show them again later.
Thanks, Howard. Those are beautiful examples of that. Wow.
Yeah, very nice, aren't they?
All right. I'll talk to you guys next week.
Thanks, everyone.
Thanks, everyone.
Bye.
Bye-bye.